Greetings, this is Dr. David Daniels, a pediatric neurosurgeon at Mayo Clinic. Along with my co-authors, Victor Liu and Dr. Rick Boop, who's at St. Jude Children's Hospital, I am pleased to provide an audiovisual summary of our chapter titled Pediatric Supratentorial Hemispheric Tumors. Management algorithm. There are many approaches to consider when managing these type of tumors. First, they can be divided into different types based on their history, what types of symptoms the patients are presenting with. But most of the time, we divide these into the features that we see on imaging, specifically MRI. Some of these tumors can be well circumscribed and in usual locations such as the temporal lobe, where others can have intermediate features, while others can be diffuse and or be in eloquent regions of the brain. For lesions that are well circumscribed or in non-eloquent regions, one of the first attempts is to obtain a gross total resection if possible. If the tumors are located in more eloquent regions of the brain, such as the thalamus, or more diffuse in nature and spread into other areas, one may need to consider a needle-guided biopsy up front. Then, based on the overall pathology, potential adjuvant therapy may be needed. Sometimes tumors that are low grade may not need any additional treatment, whereas other tumors may need chemotherapy and or radiation. And as we've progressed in our understanding of the molecular features that drive these tumors, we have more potential therapies and options to treat them. History is an important factor when determining the overall workup and initial management of these lesions. The history itself can lead a lot of substance into whether we think these tumors might be benign or malignant. Symptoms that occur rapidly and quickly, we certainly think of going along more with malignant pathology. Symptoms that occur more gradually over weeks or years, we think of as being caused by more benign types of tumors. Hydrocephalus can occur rapidly in the setting of supratentorial tumors, and this leads to headache, nausea, and vomiting. And we'd be suspecting tumors in the third ventricle or pineal region to potentially account for these. Seizures can be another prominent factor. One of the most common locations in pediatrics is the temporal lobe. Visual and endocrine deficits can be a prominent factor or a prominent symptom, and these can be seen in tumors that are located in the cellar/supracellular space. Workup usually commences either with a CT scan or an MRI scan, and usually depends on the urgency of which the imaging is needed. If the patients present to the emergency room, a CT scan is the typical workup for an acute problem. However, most kids have a more subacute presentation, and an MRI scan is definitely the way to go. This would be an MRI scan with contrast as the first line workup. Let's briefly discuss well circumscribed and superficial lesions. In children, these typically belong to the low-grade glioma class. This would be pilocytics or gangliogliomas. In really young children, large cystic lesions with kind of a mural nodule could be a desmoplastic infantile ganglioglioma. And in older children, ventricular-like tumors such as saga occurring around the foramen of the lateral ventricle or in the septum with a central neurocytoma are also quite common. These type of tumors are typically managed with surgery, and safe maximal resection or gross total resection would be curative. Sometimes these type of lesions do need adjuvant therapy, but typically the low-grade glioma variants have a really good long-term prognosis and can be managed surgically. Here's an example of a subependymal giant cell astrocytoma. This occurred in a 17-year-old gentleman who did not have a history of tuberous sclerosis but presented with headaches. Ultimately, an MRI scan showed a large left lateral ventricular lesion with enlargement of his left lateral ventricle. Because he did not have a diagnosis of tuberous sclerosis at that time, surgery was the first step, both to obtain a tissue diagnosis, but also because his ventricle was being trapped on that side. The finalized pathology was a subependymal giant cell astrocytoma. This patient has done well and is likely cured from this lesion. I should point out that in patients with known tuberous sclerosis, another option is treating with medical therapy. Specifically, mTOR inhibitors have been approved for treatment of these lesions and work very well. One of the problems, though, is we do not know how long we need to treat these patients for. A lot of times when we stop treatment with the drug therapy, the lesions grow again. That is something that we need to figure out and work on with future studies. Diffuse lesions and lesions in eloquent cortex. Lesions that are diffuse throughout the hemispheres can include high-grade gliomas, ATRTs in younger children. In the thalamic region, we can have diffuse midline gliomas. There can be low-grade tumors in the thalamus that do not have the histone mutation. And then tumors that are potentially low-grade but in eloquent regions, such as the optic pathway gliomas or lesions that are in the sensory motor cortex, etc. Most of these lesions require a tissue diagnosis and therefore a biopsy would be appropriate. Sometimes these bigger, kind of more diffuse lesions like high-grade glioma or ATRT can be resected safely, but that depends on their overall location and how they integrate with the surrounding brain. Most of these lesions, if they're not completely resected, would need some other type of therapy, such as either chemotherapy or radiation. Specifically, high-grade gliomas or the diffuse midline gliomas are treated with upfront radiation, plus or minus chemotherapy and or part of a clinical trial protocol. Treatment for optic pathway glioma would really depend on the symptoms and whether it's growing and whether there's a potential targeted agent for treatment. Here's an example of a diffuse lesion in eloquent cortex. This is a 4-year-old that presented with a seizure and had this large, mostly non-enhancing T2 weighted lesion in his right parietal region. He underwent a biopsy up front, and the pathological diagnosis was a diffuse anaplastic glioma. The family declined further treatment at that time as he was doing well with his seizures just on antiepileptics. The family wanted to proceed with therapy if he had additional symptoms or if imaging showed that the tumor got larger. Interestingly, over the 4 years that we followed him, the tumor has not enlarged in size and his seizures have remained stable. Therefore, no further treatment has been given to this child. However, based on his overall age at the presentation, and now certainly being 8 years of age, surgical resection in an eloquent region like this, and as it feathers down across the corpus callosum, would not be advisable. This would likely be treated with radiation now, plus or minus some type of chemotherapy, based on potentially new targeted agents that could be identified with his tumor pathology. Some tumors are neither well circumscribed nor diffuse and lie somewhere in between. Numerous lesions can occur in the hemisphere in children, most notably a hemispheric ependymoma or some other type of tumor like a ETMR, an embryonal tumor with multi-layered rosettes. The overall location and size of a lesion, as long as it's not in eloquent cortex and is somewhat superficial or potentially into the ventricular system, can be resected as safely as possible, with the idea of trying to get a gross total resection if possible. And then some of these pathologies need adjuvant therapy, such as radiation in the setting of ependymoma, or chemotherapy and radiation, usually in the setting of an embryonal tumor. Here's an example of an intermediate lesion. This is a fairly large lesion that was found in a 1-month-old child who had fussiness, bulging fontanelle, and increasing head circumference. The lesion was found to be between the two hemispheres and evading into both ventricles. Her overall blood volume was quite small based on her age, and a gross total resection was not possible due to the blood volume and the fact that the lesion wrapped around her internal cerebral veins. She had a subtotal resection initially, and this was found to be an embryonal tumor with multi-layered rosettes. She underwent multiple rounds of chemotherapy. She was treated for seizures with antiepileptics, as well as a shunt for hydrocephalus. She remains well over 2 years out from her initial diagnosis. Adjuvant therapy is required for some brain tumors. Specifically, some tumors can't be treated surgically, such as an optic pathway glioma, without hurting the patient. Or if the tumors are fairly aggressive, they may need more therapy, such as a hemispheric supratentorial ependymoma. Traditional therapies outside of surgery would be standard chemotherapy, such as carboplatin and vincristine. Radiation therapy is also a mainstay and effective at treating certain types of brain tumors. This is typically in the way of fractionated therapy, and now over the last 5 or so years, proton beam radiation has become the gold standard for these children. Gamma knife stereotactic radiation can also be given in certain situations. However, excitingly, there's a lot of novel therapies coming down the pipeline. There's immunotherapy trials that are ongoing with anti-PD-L1 inhibitors. There's viral agents that are being tried. And probably over the last handful of years, some of the more exciting work has also been done on targeted agents. We know that a lot of these tumors have molecular pathways that are overrepresented and overactivated, such as the MAP kinase pathway. There are BRAF inhibitors and MEK inhibitors that can work on this. And excitingly, such as SEGA tumors can be treated now with mTOR inhibitors. I think over the future now, we are going to have a lot of exciting options and new ways that we can treat patients.